Okay, thank you very much. First of all, good afternoon and thanks, really many thanks for the opportunity to present, and I hope also you have time for discussing this really innovative topic that is hadrontherapy. So it's a relatively new word, but it is a special type of radiation therapy. So we have to put hadrontherapy, particle therapy in general, in the frame of radiation oncology that, as you know, is one of the most important therapy in cancer care and management. Hadrons, sorry, just to move because hadrons. What are hadrons? Hadrons are charged particle. Different number of atoms. Proton is more basic one, and carbon ions is heavier. Hadrons, by definition, are made by quarks. This word has been introduced in '93 in the CERN in Geneva, but you can find in PubMed in general and in the internet other words used in other part of the world meaning the same thing. One is EV particle radiotherapy for specific particles like neutron therapy, proton therapy, and CIRT that is used in Japan to indicate carbon ion radiotherapy. You can see here a list of different hadrons, and we have a long history. It's not a new concept. It's more than 60 years that proton therapy has been introduced in clinical setting, but very limited experience at the beginning. Proton and neutrons was the first, followed in experience in United States, in Berkeley, by helium and neon, and followed, starting in '90, the use of carbon ion that started in Japan in a center, NIR's National Institute of Research, in which carbon ion has been extensively used, and up to date more than 11,000 patients has been treated. There is also a very strong interest in introducing new hadrons, new particles in therapy. The most promising are boron, argon, and oxygen. So we have a shift from lighter to heavier particles. You can see here the difference in terms of weight of different particles. Electron, that is basically produce X-ray, that is the lighter and is more easy to be produced by LENAC accelerator today. We have heavier particle like proton, and we have nucleus of carbon that is made of 6 proton and 6 neutrons. To accelerate this kind of particle, you need to have a very huge machine, very huge synchrotron in this case. And you can see the synchrotron that has been built in Cnao in Pavia. Is a very huge machine that has been designed in the CERN in Geneva by a previous project, the PIMS accelerator in Geneva, and has been realized in cooperation by the Terra Foundation, by the CERN in Geneva, and by our ENFN, that is the Italian Institute of Nuclear Physics, of course, including the Cnao group. You can see here a map of the distribution of the center. You can see that there are not so many. Most in the United States, only protons at the moment. We have center in Europe, and we have center concentrated in the east part of the world, maybe in Japan mainly, and something also in China and in Korea. What is really impressive is the increased number of patients treated by hadrontherapy, especially in the most recent years. You can see very strong ramp up of this curve that is parallel with the increasing number of centers. So, of course, if you have many centers, most centers, you can treat more patients, of course. And you can see that the number of patients totally treated by hadrons, the majority with protons, of course, at the end of 2016 is very high. So we cannot consider experimental treatment, this kind of radiation therapy, due to the very huge experience in clinical setting. Just to give one in Lanzhou, we have 3 centers in Europe. One is a joint center between the University of Heidelberg and the center in Marburg. The other one is Cnao here in Italy and in Pavia. So very few in Europe, none of them in United States at the moment. There are projects for this. But at the moment there are no active center for carbon ion or other particle, with the exception of protons. Why is of medical interest the use of particle therapy instead of X-ray, means conventional radiation? Because we have very high physical selectivity. So it means we can translate this concept saying that the dose is distributed in a very concentrated way, exactly corresponding or more corresponding to the size, the shape of the target. And you can see here, very easy also for not doctor, to understand, based on the distribution of the isodoses, that in spite of the progress of radiation therapy with a very sophisticated technique like intensity modulated radiation therapy, MRT, or radiosurgery, you can see that the distribution of the dose, so the capability to give the dose where the dose is needed, is higher using particles for their intrinsic characteristics. That are summarized here, inverted deep dose profile, break peak, defined penetration depth, so we have no exit dose, less lateral scattering, especially for carbons, and reduction in general of the integral dose. Integral dose means the dose, even low dose, that receive a large portion of the body. And the main goal of hadrontherapy, of proton and carbon ion, is to spare organ at risk. This is very important for the tolerance of the patient for the treatment. And you can see a very nice example of this, how it's possible to spare very fine structure like the carotid artery, like the optic nerve, like the mandibular bone, like the brainstem, like intestine, like maybe small bowel, nerves, rectal wall, etc., etc. So this is the first goal of this kind of therapy. So differentiate a lot the dose between the target, the tumor, and the organ at risk. Higher as possible, lower as possible. There's an example. We can translate this kind of therapy in clinical setting. One of the most frequent complications for patients that are treated by radiation therapy with head and neck tumor is xerostomia. Xerostomia means that the patient has a very strong handicap in swallowing, etc. And so you can realize with the MRT and better with proton, you can realize the sparing of the parotid gland and maintain in this patient an adequate salivary flow. Another typical tumor treated by protons and carbon ion is chordoma and chondrosarcoma 2 at the base of the skull. Base of the skull is a very difficult area to be irradiated because the location, because the important structure, anatomical structure around the target. It is, if this structure, especially nerve, peripheral nerve, receive more dose than the dose of tolerance, they can create a lot of problem in the patient and in the quality of life of the patient. We have very historical, very solid, very robust data on skull-base chordoma and chondrosarcoma that we can summarize like this. 5-year local control in chordoma. The report in the literature show from 60 to 80% of local control, so it means care of this kind of tumor, that increase in chondrosarcoma that is more sensitive to carbon-io, for example, 80 up to 98%. That is very important result in oncology. I mentioned it before, the integral dose. You can see here a comparison between different technique, conventional radiation therapy and hadrontherapy for the treatment of a prostate cancer. And you can see that the integral dose, so that the dose that receive, as I said, in larger portion of the body around the target, with using proton is 3 times lower. This reduces the risk of complication, but it is particularly important in pediatric age, in which we have to make a maximum effort in order to reduce this kind of dose, because the risk of secondary tumor induced by radiation, that is a clinical problem of very young babies irradiated, and also in order to avoid any problem in this growing organism. Another very important and very huge experience using proton beam therapy is the treatment of uveal melanoma. This is useful in order to avoid enucleation of the eye in the patient. The patient can be cured by surgery, but of course they have a lack of the eye, of the anatomical structure, and also the visual acuity. The result, treated this patient with proton therapy with only 4 fraction of treatment, that means less than 1 week of treatment on outpatient basis, is to obtain a cure rate of more than 95%, physical high preservation of more than 90%, and about 50% of this patient cured can maintain visual acuity. So not only anatomical safe, but also functional safety of this treatment. In Cnao we started to treat high melanoma with quite original technique, new technique, also with some device that has been developed in a project joint with the Polytechnic of Milan, and up to date we have treated 27 patients, not so many at the moment, but an increasing number of requests. This is in order also to avoid migration of Italian patients outside of our country. Physical selectivity is a property both for proton and for carbon ion. In addition, carbon ion has a unique characteristic that we're more active from the biological point of view. So it means that we give the same dose, the same physical dose of X-ray protons, and on the other side, we give the same dose of carbon ion. The capability to break the DNA is 3 times more effective using carbon. So this allows to overcome a phenomenon that is one of the major problems in conventional radiation, that is the radio resistance. So some tumors are very radio resistant, and they develop a great capability to repair the DNA damage induced by X-ray therapy. We have different tumors that, of course, we have to select. I would like to be clear, it's not for all this kind of therapy, at least in this moment, in this time. In the future, I don't know, maybe. Depends on several things, including the cost of this treatment. So we have a list of conditions in which the phenomenon of radioresistance is really important: genetic alteration, low proliferation status, intratumoral micromilieu, that means deprivation of oxygen in the tissue and in the cells. Also, cancer stem cells are very radioresistant, and also what's interesting is a topic of research for the moment is some effect on immunomodulation of EV particle. But this is what I've shown is classic indication, but we have a lot of new indication. There are several trials in the United States, in Europe, in Italy too, in our center, in order to enlarge, to establish on the basis of the rule of evidence-based medicine, if it's possible to propose this kind of therapy for other indications. And there is a very great interest in developing and in applying this therapy in the brain, head and neck, but also in the so-called big killers like lung, like gynecological tumor, like breast, like prostate cancer. And an estimation may be for the next 3-5 years that up to 20% of the total number of patients currently treated by radiation therapy, conventional radiation therapy, are suitable to be treated by particle therapy. That means thousands and thousands of patients. Cnao in Pavia, you can see just some picture of the center. We have the synchrotron that I showed before, with 3 treatment rooms, with 4 beams, 3 horizontal beams, 1 vertical beam. We have 3 treatment rooms fully operated with 3D and 4D imaging and robotic coach, etc. What is this of interest for Cnao, I believe, is a new experimental room that is under construction that will be ready at the end of this year in order to test another ion that I mentioned before, the helium, that is very promising new particle to be extensively tested in clinical setting. We have to conduct an experimental phase in order to get the certification, the CE level for the machine, because it's been built, as I said, fully in-house, so it's not an industrial product. And we move to the clinical phase in the frame of National Health System, started from January 2014. Some more detail. Cnao is quite unique because it's a dual system, so the synchrotron is able to accelerate using 2 different sources, both protons and both carbon ion, and in the future other additional particles. You can see the robotic room with very sophisticated and again in-house made system for patient positioning, patient setup, and check of the quality of the treatment. This is a summary of the clinical activity of Cnao, about 1,300 patients, the majority, 900 patients with using carbon ion with hypofractionation, NIR's fractionation. That means that the range of fraction in minimum 4 fractions, maximum 16 fractions. So that means that is very short and shorter with respect to the other type of radiation therapy, including proton, which we have treated 370 patients using conventional fractionation. That means 2 grays per day. The treatment lasts 6-7 weeks. This is distribution. You can see that we are treating several types of tumor. The majority of these tumors are in the head and neck region, about 40%, and about half of these tumors are salivary gland tumors. That is very rare, but we are collecting this case that we referred by several other centers. And the other is sarcomas, typical radioresistant tumor, meningioma, chordoma, I mentioned before, and also other. Very shortly, because we are not in a medical meeting, so in strict sense, and an example of a very huge chordoma. You have shown the anatomical picture before. This is MRI imaging, and a really good and early result of fully locally controlled. This kind of tumor don't develop metastasis, and so means that local control can be translated in definitive cure of the patient. This is the result of our initial experience. Anyway, good number, again, rare tumor. Local control is 85% for chordomas, higher than the average of the literature, and also very good result in terms of chondrosarcoma, the higher level, 97%. We have to face also very difficult case like this, because we have a selection related to bigger mass to treat with respect to the daily practice in radiation therapy. You can see an example of very big chordoma of the sacral region that we have treated, like others. You can see here very good screenage of the tumor, applying 74 gray equivalent in 4 weeks, 16 fraction of intensity modulated hadrontherapy. One of the issues, again, is radioresistant tumor, mucosal melanoma. Melanoma is not only in the eye, is not only in the skin, but also in mucosa. It's quite rare. And we treat this kind of patient that are most frequent in East Asia, but also some cases in Europe and in Western countries. You can see here an example of treatment. You can see here the huge mass at the beginning, and very well status of the patients. There is also other option, of course, alternative surgery. Very demolitive surgery is an option. I apologize for the next slide, but I would like to give you a strong message. So, CIRT, carbon ion, can change the paradigm in terms of quality of life of the patient, and without any problems related to the efficacy of the treatment, because this kind of solution is not probably the best for the patient. So when I speak about changing the paradigm, means to cure the patient, but also to maintain an acceptable quality of life of this patient. In Italy, strange, has been approved a list of tumor sites that can be offered in the frame of national, so means fully covered by the national health system. This is the list. I mentioned most of these cases, and recurrent tumor is another topic, and especially patient with immunological disorder, and again I would like to repeat indication for children, pediatric solid tumor. We are experimented also in other tumor site. Pancreatic cancer is, especially inoperable pancreatic cancer, is very difficult to be cured. There are very interesting results in Japan, about the double in terms of survival with respect to the best standard in the United States, and we are good result, limited series at that time, at 82% in locally advanced pancreatic cancer at 1 year follow-up is a very good result, and we'll start very soon an international randomized study that involved the Southwest University in Dallas, in Texas, the center in Japan, and the Cnao in Italy. And we are develop a technique in order to treat tumors that are moving during the treatment, the 4D moving organs treatment. I would like to avoid any, just to give you an example, we can modulate the beam according also to the position, the different position of the tumor. Very sophisticated technique that at the end allow really very good coverage of the moving target and avoiding not useful treatment of those to the organ risk surrounding the cancer. Pancreatic cancer is an example example, either liver cancer, primary or secondary metastatic liver cancer. It's a very difficult case. You can see here a typical, a rare, very rare tumor, but very difficult to be cured. Sarcoma, angiosarcoma of the heart in a young woman. Future develop is the project, the InSight project, that is the capability to have a quality assurance system using a PET detector in order to assess and to check that the perfect correspondence between what is being evaluated as in provisional plan and what is being really given to the patient in the practice. We can conclude that at the moment, Hadrontherapy seems to be very effective. I tried to show some data on that, and surely is a safe, of course, in terms of comparison with other therapy, and the example that I shown is maybe clear. Thank you from all of us, from the Cnao team, for your attention.